Thank you guys for jumping in on this video. In general, EAC has seen a lot of changes over the last year and a half, 2 years, as we transitioned from the downtown ministries to the space in the CVS, or the Clinical Learning Center. And these have been driven by both more access or greater access to different demographic groups, as well as with an open floor space, which allows us to really observe and keep an eye out on more students, and then also with some of the changes that the electronic medical record has allowed as we progressed. So kudos to all of you guys who have really stuck it out with us and helped us out during this time of growth and therefore growing pains. Now, this overview is really looking at trying to enhance some of the cohesion between the academic preparation and what the students are being asked to do in EAC Clinic. So this is really just to help them out with pairing the two and getting them prepared for their coming clinical affiliations or internships. Some topics we'll look at are how we're interacting with the students and their use of patient problem statements to condense that interaction, but also to condense and solidify their clinical reasoning process. So very big topics, and this is going to provide a general overview for you. Student interactions, historically, because of the way that the ministry was set up, were very student-run as well as led. However, now that we've moved into a space which allows us to observe all of the students at the same time, it allows us to take over that natural lead that's supposed to occur in that affiliation or internship model, so that the students are able to do most of the work and most of the prep, but we're able to lead the discussion and lead some of the reasoning when that reasoning seems to have gone astray. Now, just to remind you of our delineations, really if the student has finished their first fall and spring semesters, then they are considered a senior student. Anybody who's still in the first fall or spring semesters is considered a junior student. And most of our interactions are going to be with those senior students when we perform the task or role of being the clinician for that night. So the areas that we're monitoring are really both areas of patient care, both the evaluation and the follow-up. And the hope is that using both some strategies discussed here as well as a method for communication is that will allow you to monitor them with greater ease as well as guide them with greater ease. And the way that we're going to use, or the format that we're going to use, is using patient problem statements to really enhance that communication or interaction that you have with the students for both diagnostic purposes, but also for follow-up intervention as well. So a patient problem statement is really based off the residency model, in which the attending physician is going from patient to patient to patient, and individual residents are providing the background on the patient and the direction they think the care should go based off of the findings that they've had. The way that we're going to use this is that we're going to use it to help them out with that transition from inductive reasoning, where they're literally measuring everything under the sun and they don't really have a purpose to that, to being more hypothesis driven in their measurements, both subjectively as well as objectively. And they're going to have time points that they're going to come and talk to you about that. So the first thing that they're going to consider when a patient walks through the door is the demographics. And we'll go over why they're going through this, but looking at the age, the sex, the activity level of the patient is really going to help them out with the initial hypothesis generation. From there, we're going to ask them to go ahead and perform some key subjective information or subjective questioning that looks at the complaints, the functional limitations, pattern of symptoms, and various other things in there. And then once they're done with that, they're then going to come back to you. And when they come back to you, they're going to report everything in as clear and concise a method as possible, where they're going over that demographic information, the key subjective findings, and then they're going to provide their current hypotheses in an order, both the primary hypothesis first and then differential working hypotheses that they have after. Now, the main reason that we'll use this format is it not just creates a clear picture for you, but it forces them to try to create a clear picture for themselves. It also will help them out with ensuring that they do testing in the objective component to both rule in their hypothesis and rule out the differentials. So once you're done with that reporting, they'll go back and they'll do the key objective findings with any additional changes that you've created. You might have known of a different hypothesis that they need to consider or didn't consider, so you can definitely tease that out. But once you do that, they'll go back and perform their objective testing. Once the objective testing is done, now they're going to do the same thing. They'll come back and give you the final patient problem statement, which will include the various information above, but it'll now finish up with this patient's complaints are most consistent for this diagnosis. This is supported by X questioning or testing, and then I ruled out these diagnoses by way of these questions or testing. That way you can see the reasoning process as clearly as you possibly can. Now, the reason why we're using patient problem statements is because we're starting to implement this on the academic training side to enhance their clinical reasoning prior to getting out to their internships. And the way we do that is we use these charts. And the chart typically will have an overlying theme. In this case, you can see that we have a sulcus, superior sulcus tumor or Pancoast tumor, cardiac referral, and costochondritis, in which the presenting complaint is typically going to be chest pain or some sort of shoulder and upper extremity pain. Now, when they go through and they create their chart, they're going to pull common demographic or epidemiological information for these different diagnoses. They'll pull out some key subjective findings that are similar across that diagnosis. And then from there, they'll do objective findings. So they're learning the chart in the same way that they're going to report the information for you. Now, the way that we'll use these in differential diagnosis is instead of studying the chart this way, they're going to study the charts down as well. That way, when they ask a question or consider a patient's age, they can put a small mental checkbox in this diagnosis and maybe not this one, which helps them out with internalizing the different diagnoses or the different patterns that we've seen in clinical practice. Now, of course, we don't give them the patterns for every known diagnostic feature or every known diagnosis that we have. There's just not enough time for that in a generalist preparation format. So there are going to be definitely things that they are not familiar with that you might have to draw attention to, but this is how we're trying to improve their clinical reasoning and move them towards that hypothesis-driven testing versus inductive reasoning methodology. So that's the format for our evaluations. Moving on to follow-ups, we're going to ask them to do a similar thing with the follow-ups. However, it's a little bit more focused towards why they're doing what they're doing. As I'm sure many of you have seen, there does tend to be this fallback where the students will look at the previous intervention period and then give the exact same interventions. Hopefully, the patient, having performed their home exercises, no longer needs some of those previous interventions because we've improved that impairment, and now the next impairment on the list needs to be addressed. So with these, we're going to use a patient problem statement too, but they're going to create this from the initial evaluation as well as the immediate treatment prior to the one that they're seeing the patient for. Once they've reviewed that information and then had a little conversation with the patient, they're going to perform a timeout. They'll come to you, give you the quick background, and then what they think is going on. From there, you'll discuss different things that the student needs to test for, different things that you think might have occurred in the meantime since the last visit. And then from there, they'll go and they'll check those key impairments. They'll look to see if the same issues are present. If they're present, then they'll continue to work on those issues. If they're not present, then it's time to move on, of which we've asked them to go back to the evaluation and look at the impairment list and see what else needs to be addressed in clinic. Once all is said and done with those impairments and they've checked, they've seen if they are there or if they're not there, before they start to really get into there, we're also asking them to come back to you to give you a final update on the impairments and what they plan to do for the intervention that day. So just like with the evaluation, they'll have a timeout to discuss that history and what they think they need to check. they'll go and check those things, and then finally they'll come back and report on the impairments in their plan for intervention. So that's follow-ups. Now, some key things that we'd like you to try to do to stimulate the reasoning and help them out with this process are really going to be avoiding giving the answers. Especially when it's busy, the tendency is to just want to give them the answers or say, why don't you look at this test? Why don't you look at this impairment? Ask them through anatomical and physiological methods to recall what type of impairments or what type of limitations they might have. So really trying to tease the answer out of them versus giving them the answer is ideal. Now, of course, it can be busy at times, so if you don't have the ability to do that, you can give them the answer, but we'd like you to verbalize the reasoning. So that way they can at least see that higher level clinician's clinical reasoning and they can consider that. And then once you're done with that, if there's subject matter that you know they've already done, you can tell them, I need you to review this. Or if it's something that you don't think they would have seen in their preparation to this point, you can give them some outside references. Ideally, having some follow-up is going to be best. So if you can get that student just a very small, nothing that takes more than about a half an hour to search on your reasoning, why you chose what they did through PubMed or some other validated research mechanism, you could do that and have them report to you via email. That, I think, is going to really help out with them getting some idea of reasoning and what reasoning involves without, unfortunately defaulting to just an answer. So again, this is just supposed to be a short video for you guys to get an update of what we're trying to do from a reasoning standpoint. As per always, let me know if you have any questions, and if not, I'll see you at EAC. Bye.